Hello, this is Al Ali, your PSEN editor again, and this is our 1-year anniversary. We introduced, or the first meeting we went to as PSEN was the American Society of Aesthetic Plastic Surgery meeting last year, and this is our 2nd year. The American Society of Aesthetic Plastic Surgery meeting every year covers the entire range of aesthetic procedures, both surgical and non-surgical approaches. And this year is no different. It is an excellent program that covers anything from breast surgery to facial surgery, body contouring, injectables, lasers, and the entire range covered extensively, anywhere from the level of a beginner to an expert.
Hi, I'm Dr. Stephen Wallach. I'm the section editor for the aesthetic section of Plastic Surgery Educational Network. We're here at the meeting to get some great video for the website, which is a great educational tool for both our members as well as the residents of the various programs around the country, and we hope you enjoy the information that we provide to you.
Today in sunny Vancouver, I had a chance to moderate the multi-ethnic, multicultural rhinoplasty panel. We had 4 outstanding panelists share their experience from the African nose to the Asian nose to the Middle Eastern and Latin nose, and this gave us a great opportunity to talk about various techniques that are very innovative, that are designed to increase the predictability of rhinoplasty while minimizing the potential complications or difficulties that can occur, especially in an ethnic rhinoplasty.
This panel was called "How Long Will My Facelift Last, Doctor?" And the idea was that we would try to first find out from the surgeon's perspective how they answer that question, or what their feelings were about how long a facelift does last or should last. And we tried to answer some of the questions in regard to whether or not early recurrence of aging was a result of loosening of the surgical suspension. Were there types of patients that tended to recur earlier? Do secondary facelifts do better in the long run than primary? And also, from the surgeon's standpoint, what anatomic criteria are they looking at to try to determine whether the facelift was going to last longer or shorter?
I think if you had to sum up in one word what's hot, is fat. How it works, where we inject it, face, body, breast, buttock. Fat is hot. The key is, what's its applicability? Where is the science? How are we going to advance it? What's the role of stem cells? These are all the questions that we're looking at the Aesthetic Society level, at the educational level. And obviously they'll be continued as we go on to our next meeting at the ASPS in New Orleans. And I think one of the key elements is that we will bear this out with hard science and facts in the next 6 months when you see upcoming articles on this hot topic in the Journal of Plastic and Reconstructive Surgery.
This meeting really showcased a lot of experts in the field of cosmetic breast surgery. We're really relying on total correction of difficult secondary problems using standard plastic surgery techniques supplemented by acellular dermal matrix and other technologies. So we really can bring our patients results on a fairly consistent basis that we couldn't realize as few as 5 years ago. So things like revision of previously done either mastopexy procedures or augmentation mastopexy procedures really are now being routinely done with a high level of consistency.
There was some excellent information learned about the use of acellular dermal matrix and fat grafting for breast cripples, patients who have had multiple operations with breast implants that had deformities that have been nicely improved with recent advances both with Stratus and fat grafting techniques.
One of the great panels I saw was on the evaluation of when do you transition between non-surgical, all the things we do as plastic surgeons of fillers, Botox, skincare, to surgery. And it was wonderful because it really delineated the limits of what many of these things that are promoted to the public as achieving don't achieve. They're not replacements for surgery. They have a role both during the procedures, before and after, but they're not replacements. So the information about reality, eliminating the spin, is invaluable, and that really needs to get to the public.
We just discussed cartilage splitting techniques in closed rhinoplasty, and there is a definition of vertical dome division that encompasses a broad variety of techniques used for the lower lateral cartilages that starts with the Goldman tip. And my presentation was not about the Goldman tip. It was actually more akin to the old Lipset or Foman tips, with a little bit of a variation where the incision is made in the middle or medial crura without morselization of the cartilage to allow for rotation and improved projection of the nasal tip.
We just finished giving an instructional course with Grady Core, talking about transaxillary endoscopic breast augmentation and processes and refinements to optimize outcomes. We've tried to emphasize the specific aspects of the surgical technique that allow us to get consistent results. That can include the initial incision planning, the issues relating to the tissue release, how the muscle's divided and at what level, implant choices, contrasting saline and silicone gel, emphasizing post-op routines and follow-up protocols that help us get consistent results with the technique.
Michael Shefflin came the longest for Hot Topics or the panel from Israel, and he talked about his experience with bovine-derived acellular dermal matrix and 300 consecutive breast reconstructions. He showed good circulation flow, good ingrowth, and it was really good technical hints and so on. So it was a good study. And then we had what's called a Pecha Kucha, and that is a debate style presentation where you have 20 seconds to present each slide. And Steve Teitelbaum kicked that off with his assessment of the poor results he's seen long term from patients who've received high profile breast implants. He was really down on them. And the second one was from Jim Nakbar, Pecha Kucha, and Jim talked about the electronic medical record, some of the ins and outs of that, having your data on a server in the office versus on the cloud with a double connection, and where we're going and what the incentives are. And the bottom line from his talk that came out in the question and answer period was that do what you're doing right now and you're comfortable with. If you're not doing Medicare or Medicaid, there's no problem with not having the electronic medical record. And he said, don't make any decisions on the incentives.
The meeting's been terrific. It always is. The Aesthetic Society meeting is the premier educational forum for individuals who do aesthetic surgery. There's a wealth of information between the teaching courses, the panels, which are superb.
I think it's been a very exciting meeting.